Okay, the last section for pharmacology is pain management and psych meds. So the first thing with pain management is we need to know how to assess pain. Um, Patients have said that 0 to 10 scales don't feel very helpful to them, but we do have to have some way of documenting changes in pain and whether our interventions are effective. Make sure that if your patient is not able to give you a 0 to 10 scale assessment, you use other methods of pain assessment. There are methods for patients with less verbal ability. There are methods for patients that are unconscious. There are methods for children. There are methods for neonates. There are methods for patients with dementia. And a lot of those are based on pain-related behaviors. So make sure that you're using an appropriate pain scale. When we talk about medications for pain, acetaminophen is one of the most common over-the-counter meds. What we need to know, it has an antiprostaglandin action. It has less anti-inflammatory properties than Nsaids and aspirin, so it may not be quite as good for pain that's related to inflammation. And it is toxic to the liver in excessive doses. Max 24-hour dose of acetaminophen varies by expert, but 3,500 to 4 grams typically. Some will even move that down a little bit. If you have a patient who is more at risk for liver damage, you would want to lower that some and maybe encourage them to take different things. The next category, aspirin is not quite an NSAID, but it works very similarly to a lot of NSAIDs, or to the NSAIDs. It is acetyl salicylic acid. It also has antiplatelet effects, so patients may be taking it for that effect. Aspirin is associated in children with Reye's syndrome when it's taken with a viral illness. So we don't give a lot of aspirin to kids anymore. And if they have a viral illness, it's contraindicated. There are a few specific pediatric disorders that aspirin is used for. Otherwise, we don't give it to kids very much. NSAIDs like ibuprofen, ketorolac, Meloxicam can be very, very effective for pain management. They decrease inflammation, have antiprostaglandin effect without being sedating or addicting. They are really hard on kidneys and they can cause GI bleed, as can aspirin. So aspirin and NSAIDs can both cause GI bleeding. They shouldn't be taken on an empty stomach. They should be taken with food. Some NSAIDs are very, very hard on the gut, and we have to be really cautious. Oral Toradol should not be given for more than a few days. Meloxicam is something that's taken by a lot of arthritis patients. Any arthritis patient taking Meloxicam long-term, we need to be monitoring their stool for bleeding because it seems to be fairly common. Sometimes those non-opioid pain meds are not enough, and patients need opioid pain meds. Opioids have several side effects. They tend to slow everything down. They slow thinking down. They can be respiratory. They can cause respiratory depression. They cause constipation. They can cause urinary retention. They can also be a drug of abuse. And right now we're in a place where the pendulum has swung very anti-opioid. When I began nursing, we had really just discovered that patients, or just acknowledged that patients had not had their pain adequately treated. And so there was a really big move to make pain the fifth vital sign and make sure we were managing pain adequately. And in that process, a lot of times providers were too free with opioid medications. People would go home from fairly minor surgeries with a 30-day supply of Vicodin, or that people were too free. And we did have patients who developed substance use disorder beginning with, or at least they got worse with prescribed opioids. Now the pendulum has swung really far in the other direction, to the extent that a lot of providers are not prescribing opioids at all. ERs are not giving them. Patients may be in excruciating pain that we're actually not managing effectively. I'd like to see that pendulum kind of settle in the middle somewhere, where we're actually evaluating the individual and what they need. But that's not where we are right now. What the other thing you need to know about opioids is the reversal agent is naloxone. There are also some other meds that help with pain, even though they are not actually pain medications. In particular, nerve pain can be helped by several different types of meds that slow nerve transmission. Gabapentin is commonly used for nerve pain. Amitriptyline has been used for nerve pain. But in addition, there are some adjunctive meds that we give with pain meds that make them work more effectively. So sometimes we might give, with an opioid, we might give some of the antihistamines for nausea, but also because they help the pain med work better. So promethazine is commonly given along with an opioid to help severe pain. So most important thing is know how that medication works and know what harm it can do. Psych meds, I'm going to go very quickly through these. You are going to start out fall semester with a really in-depth look at psych meds, because you're going to start in psych this fall. So psych meds, there are several different classes. There are categories, and then those categories, there are different classes. So antidepressants are probably the most commonly used psych meds. Some of these meds can be used for depression and anxiety. But antidepressants, there are tricyclics like amitriptyline, there are MAO inhibitors, there are SSRIs, and those are the things like citalopram and I think Prozac, those meds. I know I'm mixing generic and trade names. Mood stabilizers. One thing to know about antidepressants, if they have the effect of increasing serotonin levels, there's a risk of serotonin syndrome. Mood stabilizers are used often for patients who have bipolar or who have really wide mood swings as part of their illness. Lithium was one of the early ones. There are some newer ones that are used as well. Antipsychotics are used for patients in psychosis. The phenothiazines were one of the first classes of those, and they're used to help control delusions and hallucinations. All of these meds tend to have a big kind of flattening effect for patients, and they often feel like they have a hard time feeling their emotions, and they don't feel like themselves when they're taking psych meds. So that affects compliance. Patients who are supposed to be taking psych meds frequently struggle with compliance because they make them feel like not themselves. Also, a lot of them can cause constipation, and a lot of them cause weight gain and metabolic syndrome. The final categories, anxiolytics. Benzodiazepines were used for anxiety primarily for a really long time. Now you're more likely to see an SSRI as a maintenance med with maybe a small dose of a benzo as a breakthrough or an occasional medication. Benzodiazepines also can be addicting. You develop tolerance, and weaning from benzodiazepines can lead to seizures. Okay, that's it on pharm. There's so much more to know about medications. You'll be learning about medications forever. What I really hope you got from this is how to look at the mechanism of action. What is this medicine doing in the body to fix that problem? Otherwise, these are the classes of medications that are testable on this exam.